All right, well, good afternoon, everyone. My name is Autumn Mells, and I'm the OB Outreach Nurse Educator at the University of Chicago. And I appreciate you all joining me to learn a little bit more about some of the basics of preeclampsia. I know that a lot of us on here might be coming from varying experiences, so I'm going to try and respect those of you who I know I have some very new people who've maybe been in orientation just a couple weeks, and I have nurses too who've had 30 plus years of experience right in OB. So I'm going to try and respect everyone's levels of experience. So before we get started, I just want to say, just with Zoom, please make sure that you sign in on the link in the chat box if you are able to. I will throw it up there again, just so I can give you credit for attending. Please, if you do have your video on, that's fine. Please just make sure that you're muted. Always feel free to unmute yourself if I'm asking a question. And then just be aware of the surroundings, Zoom etiquette. And then I will be recording this session if that's okay with you all. So different objectives by the end of the hour. I hope that you can use this as a checklist. Is essentially to be able to say that you can define preeclampsia or eclampsia, identify risk factors and signs and symptoms of preeclampsia, understand how it's diagnosed, managed, and treated, comprehend potential complications of preeclampsia, and then apply the proper technique and equipment use for accurate blood pressure assessment, which I'm hoping this last one you guys can probably do in your sleep, right? So conflicts of interest or disclosures, I have none. I have no financial relationships. Obviously, I will be bringing up certain medications that we used, like antihypertensives, magnesium. I'm not being paid by any of those companies to speak to you about that today. So I will tell you my little caveat. When you do your eval for this class, there's 1 point on the eval to get your CEs, and that's, did the presenter disclose conflict of interest? It's confusing. The answer is yes, and I have none. So that's your 1 point on your eval. So no conflicts of interest. Criteria to get your 1 CEE is just attending the hour-long program and then completing the evaluation tool that I'll give you at the end, and you will get 1 CE if you're attending the live session that's going on right now. So to kick us off, I want to just talk about trends related to maternal mortality and morbidity in the US. Unfortunately, right, we are a very developed country, but unfortunately our maternal and neonatal morbidity and mortality rates are increasing. I know the latest report for 2020 is not released yet on the mortality morbidity statements, but I can tell you that from what I know is that unfortunately we are still seeing an increase in hypertension and preeclampsia. And we are seeing that we still need to work and improve on how we can treat these patients. Hence why we are here today. So the definition of preeclampsia, so I think it's important for us to start with the definition, is essentially that it's a multi-system progressive disorder characterized by new onset hypertension, so they haven't had it before, and proteinuria, or it's hypertension and a significant end organ dysfunction, which we're going to talk about later, with or without proteinuria. It's mostly after 20 weeks of gestation, or it can develop even closer to term. Now, I just wanted to emphasize that really proteinuria plays a small role in the diagnosis and management of preeclampsia. I remember when I first became a nurse, sometimes we would look at this proteinuria and we'd be like, oh my goodness, their protein is this high. Like they're really, really sick. But sometimes people had lower protein, maybe it was only 500 in their urine. And sometimes those people with even the lesser protein were more sick than those that were higher. So really it's not necessarily the one indicator that we're going to look at. So then what causes, right, all this stuff like the new development of hypertension, the significant end organ dysfunction, which we'll talk about those are all the signs and symptoms we'll talk about later. So what causes it? It's essentially caused by a placental and maternal vascular dysfunction that resolves after delivery. Now, I'll emphasize this again later, it resolves after delivery. You might hear people say the only cure for preeclampsia is delivery. Yes and no. Why do you think I say yes and no? Feel free to unmute. So yes, delivery may cure it, but not completely. Why do I say that? My postpartum, do I have any postpartum?
Sorry, because they're still at risk afterwards for developing preeclampsia, even with delivery up to 2 weeks.
Yeah, good. Are you a postpartum nurse, Chanel? Or no?
I'm everything. I'll do OP.
Everything. Okay. So you're all over. No, and this is where I want, my postpartum nurses, if you're on here, it's almost, just as important for you, right? If not maybe more important for you to know these signs of preeclampsia, because, and I'll emphasize later that a lot of women can develop preeclampsia even up to 6 weeks postpartum. So it's not that they deliver and they're out of the clear. I'm sure some of you guys may have even seen patients develop pre-E postpartum or even eclampsia. So yes, delivery kind of is the cure, right? But just because they had their baby doesn't mean they're in the clear. Okay. So what happens? So we think it's a placental maternal vascular change that occurs. And what happens is in the placenta, these are, it's a picture of the spiral arteries, which essentially what happens is I just want to show this other picture. Really quick anatomy of our placenta, right, is we have these maternal arteries right here, these nice and red ones. I hope you guys can see my mouse. And essentially what they do is they just dump blood into this intervillous space in the placenta. And I think of the intervillous space in the placenta as like a pool of blood, right? The baby can pick up oxygen and nutrients as it needs it. And it also dumps waste here, right, that the maternal vein can help take away. Now, these spiral arteries, whoops, like, oh no, I'm giving my answers. These spiral arteries, right, like you see on here, they're usually very wide. You can almost think of it, I've heard like the garden hose analogy, but really it's just pouring blood. By turn, there's about 500 to 800 mLs of blood that just like flows in through these spiral arteries, perfusing the placenta and the baby. And then these they can start to become very narrow, right? So if we have these narrowing of these spiral arteries, that's feeding this intervillous space, what do you think happens then with our poorly perfused placenta? What do we see happen with our baby? Any guesses? We have a big or a small baby?
Small baby.
Small, right? So then we see these are our babies that we can see this intrauterine growth restriction, right? Or these SGA babies, maybe that are less than 10th percentile. And in such extreme circumstances where maybe it's really bad, right, we can lead to a fetal demise, so fetal death. And then the very last thing from the poorly perfused placenta is the release of these pro-inflammatory proteins. And then we're going to talk about, right, so these proteins get released into the blood, right, into the bloodstream. And here's what happens, right? So these proteins are in the bloodstream. The vessels, right, the maternal blood vessels, they're going to start to like dilate and constrict. And then look what happens, like these proteins, right, in the blood, here come some of them, and look what it's doing, right, to the, oh, it's supposed to look way cooler than that, but, right, these proteins essentially are going to bounce around, right, within the blood vessels. There's constricting of the blood vessels, and it's essentially going to break down these endothelial cells that line the maternal blood vessels. It's going to break it down, right? And then we see like breaking per se, right, of the sides of the vessels. So then what happens, right? We have a bunch of fluid that's in here, and the fluid, right, those blood vessels then become more permeable because it's breaking these endothelial cells down. So then what happens to our fluid? Where does it go? Out to our tissues, right? So then what signs and symptoms might that lead to then in our patient?
Swelling.
Yeah, our swelling. So the first thing we might see is that generalized edema, right? Which you guys have seen, right? Sometimes those preeclamptic patients that are pretty swollen. Now, it can be tricky, right? The swelling. Okay, we have a woman in her 3rd trimester of pregnancy, right? Maybe she's 37 weeks pregnant. She's coming in complaining of like pedal, right, edema. Her feet are really swollen. Maybe it's the middle of summer, right? She's up on her feet all day. It can be tricky. Now, a little trick that I've heard is swelling below the waist, right, is very normal, right, in a pregnant woman. They can start to become swollen. They're trying to retaining fluid for that 3rd trimester for delivery time. But once we start seeing, are the hands are starting to get swollen, you're seeing like their facial features are starting to swell. We're starting to think more, right? Okay, is this preeclampsia swelling? So we have to be careful, right? That can be tricky to assess. The next thing then is pulmonary edema, right? You guys have probably seen these preeclamptic patients who unfortunately, right, start to develop some in their lungs. And then in severe circumstances, then it can lead to cerebral edema, right? So when you think of preeclampsia, I really want you to think of essentially these blood vessels. Some of them are constricting, right? They're narrowing. Think of now these proteins are going in the vessels, breaking down those endothelial cells, which protect the vessels. It's allowing then that fluid to seep out of the vessels, essentially leading to this swelling, okay? So now who's at risk for preeclampsia? I think you guys know, but good to review. Anyone who is in their first pregnancy is actually at risk. If they're advanced maternal age, so greater than 35, if they have a family or past history of preeclampsia, so maybe their mom had preeclampsia. I actually learned as well that there is some type of genetic component or I actually heard that even the father of the baby, right? So if his mom was preeclamptic with him, it's more likely that his offspring, even if her mom wasn't preeclamptic, that mom could be preeclamptic, something related to genetic components. So even his side of the family is important to know. Pre-existing hypertension, mom has diabetes, multiple fetuses, any history of kidney disease, mom is obese. We see some of these autoimmune diseases like ALS or lupus, thrombophilias, if they use like infertility treatments. So maybe IUI, IVF is good to know. And then a history of obstructive sleep apnea. So these are all things. And sometimes we look at a patient and we're like, they're a ticking time bomb, right, for preeclampsia. We think it's going to happen. It's just a matter of time when, right? But it was interesting. We have all these risk factors, but then a study that I read talked about that a lot of the patients, we think these are all these risk factors, and actually most of the patients were showing up with no history, right, or none of these risk factors, and they all of a sudden developed preeclampsia. So don't think that because they don't have any of these, it's a very low incidence. It can still occur in anyone. How we diagnose pre-E, I already said it's new onset hypertension. So even into these mild range pressures, which we categorize as a systolic of 140 over diastolic greater than 90 on at least 2 different occasions, at least 4 hours apart. And then the proteinuria after 20 weeks. And I'll talk about that definition a little bit. But now, you have these mild range pressures, they say on 4 hours apart, but right, sometimes we don't wait the 4 hours. Right? What if you have a patient come in who has severe range pressures, is symptomatic? It might not take you, it's not going to necessarily maybe take you 4 hours, right, to diagnose that patient with preeclampsia. So this is technically the definition, but sometimes we know it can be a little bit quicker. Preeclampsia, so remember, preeclampsia is either without severe features or with severe features. So there's 2 different categories, right? And essentially without severe features means they don't have any of the symptoms. I think that's the easiest way to remember it, and they're having mild range pressures. Now, if they have severe preeclampsia with severe features, you'll notice they're going to have these severe range pressures, which are always going to be the 160 over 110. And proteinuria with or without signs and symptoms of significant organ dysfunction, or they could have a blood pressure in the mild range and they just have 1 or more signs and symptoms of end organ dysfunction. So proteinuria, like I said, is important, and we will still do it, but like I said, it's not the #1 determinant, right, if our patient has pre-E or not. So typically we can say that their protein creatinine ratio is high if it's greater than 300 milligrams within a 24-hour period. So if they do that whole 24-hour urine, or sometimes they will look at the dipstick, which is +1 or more of protein on the dipstick if they can't get the 24-hour urine or PCR is not available. So the dipstick is really, it's kind of an old school, I guess, term I could use. We really want to try and get away from the dipstick. And the best method that I can say is, like, if you look at this pyramid, is that dipstick is the least preferred, then the PC ratio. And it'd be really nice if we could get a 24-hour urine, because it really tells you how much protein are they spilling into the urine. But sometimes we don't have 24 hours, right, to wait. So, and another nice thing too about the test is some patients can be monitored outpatient for preeclampsia, and we'll talk about who. And those patients can do 24-hour urines when they're at home, as long as they're educated on how to accurately do that. So that is nice about that as a test as well. And just a reminder, right, proteinuria is not a requirement to diagnose preeclampsia with new onset severe hypertension. So just remember, it is not always required to say that a patient has preeclampsia for proteinuria. So I've said this like 3 times, so you're probably wondering, all right, this lady's crazy about the no proteinuria thing. So what if there is no proteinuria? Remember, it still can be diagnosed in the absence. So essentially what you're going to see is they can have hypertension, right, in the mild or severe range, and then they have these severe features. So when I say severe features, right, I want you to think of those signs and symptoms of end organ dysfunction. And that leads me to talking about the signs and symptoms. And this is where I want you guys to kind of help me and chime in on what you see or what you know. So these signs and symptoms of end organ dysfunction. The first thing, we'll see some cerebral, right, signs and symptoms. What could those be?
A headache.
Good, headache.
The blurred vision.
Yep, blurred vision.
Or
Seeing
spots.
spots.
Yep, spots. Anyone, now can I'm gonna, challenge you a little bit further. Why do you see those? What causes that?
The capillaries in the eyes are the blood pressure is so high that the capillaries in the eyes are affected.
Okay, good. The blood pressure is increasing so high. And then remember, those vessels too are constricting, right? So there's more pressure on the vessels as well. So it can lead to that. The other thing too is, let's say, for example, if we did have cerebral edema, right, there's more pressure then from fluid as well, which could lead to some of those signs and symptoms too. So remember with the headache as well, the headache is, patients will oftentimes describe it as like the worst headache of their life. It's not going to respond to Tylenol as well. So if we do try and give them like that gram of Tylenol, it's really not going to make a difference on their headache if it is related to preeclampsia. So then we have some abdominal pain. Tell me more specifics about that.
Right upper quadrant pain.
Good. What's in our right upper quadrant?
The liver.
Good. I was like, I don't have to pick on you all the time. Good. So it's specifically right where a patient's liver is. So what's the liver doing? So I'll just kind of help you, right? It's working a little bit harder, right? So we see our liver enzymes are oftentimes, right, elevated. The liver can become inflamed. So it can lead to a lot of pain, right, on that right upper quadrant. And the other thing that's might be a little bit more tricky is epigastric pain. So if your patient's complaining, it can just be as simple as just reflux, right? That you think, well, you know, you're 38 weeks, you have a big baby, maybe. We have seen it, right, where maybe that's the only sign, right, of end organ dysfunction that we see is that epigastric pain. It will not be responsive to medications either. So if they come into triage complaining, you try and give them something IV push, it might not matter, right, for their pain. So the next thing is our kidneys. What do we see there? All these things kind of go together, so you can maybe relate them together. Kidneys, we see swelling. What else?
They generally have a decreased urine output since all the fluid's shifting.
Good. Yeah, that fluid shift we talked about, like with those vessels, remember with the opening, so the fluid's going to go out into the like extravascular space. Are their kidneys working as well? No, not really, right? We hope they are. We don't want to see them at that point, right? But we can see a decrease in kidney function. So we might see some of our kidney labs, right, deteriorating. And then we can see oliguria, right, decrease in urine output. And then we then see the swelling, the generalized swelling. Remember, it'll be all the way up in the hands, the face, etc. The arms can be really puffy. And then we see weight gain. Our patients who are preeclamptic can get anywhere between 3 and 5 pounds a week, which is a lot of weight, right? Retaining a lot of that fluid. So if your patient, might have pre-E, we'll talk about if they're monitoring outpatient, it's important to do that weight gain at home. They should be doing daily weights, or if you have a patient on like an anti-unit to watch that. Lungs, this might be a little bit more advanced, but we might actually see some shortness of breath. I'll just say this, right? It can lead to pulmonary edema. Patients who are preeclamptic, because of this fluid retention that we've been talking about, are at a greater risk for developing pulmonary edema. This is why I cannot stress enough, it's very, very important to do your I's and O's. L&D nurses that are on here, I'm guilty of it as well, as I was an L&D nurse too. I loved my fluid boluses, but we have to be very careful with them, where you can push a patient to fluid overload, and we can have increased risk of poor maternal outcomes when we do that. So always watch how much you're bolusing. And then blood finding wise, I'm going to talk about lab results on the next slide. So we'll kind of lead into that. But I just want you guys to know, like, these symptoms of end organ dysfunction really give a good indicator of how far progressed this disease process is. So depending on what signs and symptoms your patient's exhibiting, you might think that this disease is further progressing, and it can happen quickly, right? So we have to make sure that we're asking all these things on our patients who we might be suspicious of pre-E with. So some different lab values. I just wanted to talk really quick on this. You guys probably know most of this, but we know typically in normal pregnancy, the GFR, so that glomerular filtration rate, usually goes up by about 30 to 50%. The BUN goes down, creatinine, it's like less than 0.8. The uric acid is less than 4.5. Your AST and ALT, those liver function tests, the liver in pregnancy should be functioning normal, right? It should be doing its job how it normally does. And then hopefully we have no protein or a trace, right, on our urine samples when we do that. But then when we come to pre-E, right, big change. These vasospasms that we talked about in preeclampsia, I'm sorry, can lead to a decrease in renal perfusion. I always think of the perspective of like, for example, say your mom, right, she's hypoxic, she doesn't have enough oxygen. The kidneys, right, aren't going to be then given as much oxygen as they need, right? It's going to go to those more vital organs, right, for the mom, like maybe her heart, right, her brain and her lungs, not necessarily the kidneys. So our kidneys are going to start declining. So we'll see a decrease in the glomerular filtration rate. So we're not going to be urinating as much. And then what happens is the BUN increases, the creatinine increases, and the uric acid. Now, I've heard of all three of these things, the BUN, creatinine, and uric acid, almost as like poisons per se, right? These are like toxins that we want the mom's body to rid. So when we see them going up, the BUN, creatinine, and uric acid, we should be alarmed, right? Like, why is this mom's body not pushing out these toxins? But then that makes sense, right? With our decrease in our GFR. And then like we talked about, I think like one of you guys had chimed in, right? So the liver is working harder. So our AST and ALT, those liver enzymes will be elevated in our pregnant mom. And then we do see as well greater than 1+ of protein when we do a urine sample. Okay. Let me see. So again, just looking at your kidney tests, the kidneys can be so far affected that patients can actually go into renal failure to the point that they need dialysis if the disease progresses enough. So this is from different labs that you might see when they're doing pre-E workup. So some other clinical pearls just to identify, make sure that when we are assessing our patient's blood pressure, our initial one, if it is greater than 140 or greater than 190, we know that we want to repeat that. So these are mild range. We want to repeat the blood pressure in 15 minutes. Should take it in the same arm. Please make sure that you're not repositioning the patient to have her arm above her heart, right? That's going to give you a false reading. And if we falsely we could miss someone, right, who has preeclampsia. So you don't want to reposition them to lay on their side. Just try and keep them semi-foulers for a little bit. If their initial BP is 160 over 110, we would need to notify the provider right away after that, because that's a severe range. So notify them first. You're going to reassess it in 15 minutes and then activate the treatment algorithm. If it's still a severe range of greater than 160 over 110, you need to start your treatment. Now, I can't stress this enough, and this is taken straight from ACOG and ILPQC, that they said that the treatment should be completed within 30 to 60 minutes of these severe range pressures. This is my own personal opinion. I think that that's very lenient, right, to sit that long and wait on a severe range pressure for a patient. Why do you think I think we need to move? Why do I say that that's too long? Any guesses? What could happen?
You could have a seizure.
Yeah, can lead to a seizure, and then our mom could have a stroke, right? If we don't lower her pressure. So I really tell people I push more towards this 30-minute, right? There's really no reason that we shouldn't be able to try and administer something within 30 minutes. So I would just kind of challenge yourself to think of that. So timely response matters. So timely triaging with evaluation identification. So example, if you have a patient come in, if you are working a triage unit, or maybe your patient's postpartum, right? Maybe she's 2 days postpartum and she's almost getting ready to be discharged. And all of a sudden she says, I have this really bad headache. I'm not feeling well. I need to do her blood pressure and it's elevated, right? So we really need to make sure that we're identifying these symptoms, and then we see that high pressure, we should move. Make sure that you have rapid access to medications and protocols. I encourage you guys, whatever unit you work on, know where all your meds are, know where your labetalol is, your hydralazine, know where your syringes are, your pushes, and know your protocol. It'll make this, right, a lot less nerve-wracking when you have a patient come in who has pressures like 200s over 110s, right, and you're scrambling to try and get her pressure down. It will help you. Make sure that you know your system plan for consultation, like if you guys need to get an MFM involved, or if you need to transfer to a higher level of care. Ask your managers, ask your educators, charge nurses, what's the process for this if you're unfamiliar with this, to make sure that you know what you need to do to get that patient somewhere else if they need to be. And then emergency protocols for eclampsia management and your hypertension treatment. Again, everyone's will be very similar. And I'll show you kind of what we use at University of Chicago. So you can look at that. So this is kind of that last objective that I talked about making sure that we obtain an accurate blood pressure cuff. Now, I'm not going to sit here and show you how to do it, right? Because you guys know how to get a blood pressure, but I do really want to emphasize the importance of failing to accurately measure blood pressure in a consistent manner can lead to a misdiagnosis. So we could accidentally maybe say that, okay, maybe someone's hypertensive. It could lead to a delay in treatment. What if we had her on our side and we used a big cuff and now it's reading lower when actually she had a severe range pressure? We can miss the worsening of disease and it can increase morbidity. It can even lead to maternal and fetal deaths. So please be cautious when you're using them. So make sure your patient is positioned correctly. We really don't want the mom laying on either side, right? If she's laying on top of it, it could give us maybe a false high reading, or if she's laying all the way over, less blood flow right to that side. It could be a little bit lower. Make sure you have the right size. I know it can be tricky, right? Sometimes you have that patient's arm and you're like, she's between a small and a large. I don't know what to do. Your cuff shouldn't be, you shouldn't be looking at it and thinking, oh man, I think it's going to pop off, right? If you think it's going to pop off, you probably need to move to the higher size cuff. So sometimes you need to work with your cuff a little bit, and that's okay, but you shouldn't be just saying, oh, I got a high reading, the cuff didn't pop off, right? We'll just say this was her pressure. Please make sure that you're getting an accurate reading. And sometimes maybe you need to call other units to get a different size cuff, etc. Just make sure that you know where that is or what the proper placement is for your cuff. So position, obviously our patients aren't sitting this beautifully, but laying in bed, right, her legs can be up to support the mom's arm on a pillow if you can when you're doing the blood pressures. The other thing is too, if you can imagine a mom who's in this situation, especially if she's preterm, how do you think she's feeling? Probably pretty anxious. Not the best time to check her pressure right after, maybe after you tell her that she, is maybe delivering preterm, or maybe she had a consult by MFM or NEO. If she was just walking around, let her rest for 5 minutes before you check that pressure. You don't want to accidentally do it after, she's running around all over the place. Give you a false high reading again. This is the algorithm put out by ILPQC. I'm assuming you guys have seen this at some point in your career, or you know it by heart for those of you that have extensive experience. This is our severe range hypertension treatment algorithm. And you can see here, right, where it talks about if your blood pressure is greater than 160/110, repeat in 15, notify the provider, and then you're going to move. Our first line of treatments are typically labetalol and hydralazine. Are you guys using labetalol first, hydralazine first, or you do kind of, which one do you see coming first more?
We use labetalol first,
Okay.
generally.
Yeah, I think that's the majority of what people do is labetalol first, and then they switch to hydralazine. You guys probably have an order set too that says this, but the only thing I just want to encourage is make sure you know your numbers. You know that it's 20, 40, 80, how long you should push it over. Remember, there's slow IV push, and then when you should check the blood pressure. It's important to make sure we're giving the correct dosages because, right, that's what the data has shown makes the difference. So don't give 20 and then give another 20, right? And then maybe give 60. The patients do better when it's the 20, 40, 80. So if they're having the severe range, we should always be moving in this algorithm. And this is supported by both ILPQC and ACOG. So those are who we should be looking to. If their blood pressure is not right, we want to make sure elevated. We want to get, well, this is both actually. You want to get IV access, make sure you're monitoring your baby, get some of those labs we just talked about and more labs possibly. Put on the pulse ox, and we're going to talk about MAG, etc. here in a second, but you should get ready, prepare for if she hopefully does not have a seizure, and then start her on magnesium. And typically the bolus dose is 4 grams over 20 minutes and the maintenance is 2. Again, this can vary based upon your institution. And you can do oral nifedipine as well. But if you're having severe range, we might not necessarily wait, right, for an oral antihypertensive to kick in. Now, it was prompted to me at one of these lunch and learns about, let's say, for example, your patient's blood pressure was normalized for like an hour, and now all of a sudden she has a severe range again. And we stopped at 40, right? My last dose I gave my patient was 40 milligrams of labetalol. Your patient's pressure is normalized for an hour. You need to restart your algorithm, okay? And the rationale for that is you're not gonna give your patient 40, she's normalized for an hour, and then all of a sudden slam her with 80, right, a labetalol. You could make that patient become hypotensive. And now think about if your patient's blood pressure, now I had a patient once whose blood pressure was 200s over 110s when she came in through triage. If you can imagine how she felt, not good. Mental status was deteriorating, etc. But Then her pressure dropped down to like 130s over, I think it was like 80s or 70s, and she didn't feel good, right? She had all those symptoms of like someone who is hypotensive. So you really have to be careful that even someone whose pressure is so high, they can start to feel like they're hypotensive around like a normal right range blood pressure. So just be cautious when you're using your algorithms. And I hope that you guys all know where these are in your unit or how to walk through them. So again, controlling blood pressure is the optimal intervention to prevent the development of stroke in women with preeclampsia. If you are ever torn of what you should do, you're by yourself, torn of what you should do first, you always want to lower the blood pressure and then get the patient started on magnesium. So if you had to pick, right, between two things, always get that blood pressure down first, and then you can start your mag. It was interesting enough, I looked at an article that talked about when do patients have strokes the most. And if you had to guess if it was the intrapartum time or the postpartum time, when do you think most patients have strokes?
I would guess postpartum.
It is postpartum. So it was, and I was like kind of surprised. I'm an L&D nurse, right? So I'm like, everything bad happens on L&D, but happens everywhere, right? So it was actually like 10% happen on 40% happen intrapartum, and 50% of strokes were happening postpartum. So pretty significant amount of the strokes in preeclamptic patients happen after they have their baby. So get that blood pressure normalized as best as we can. So when the blood pressure is normalized, then here's, kind of the whole flow of it. Once it's normal, right below 160 or then 110. So it could still be our mild range. You're going to check it every 10 minutes for an hour, every 15 minutes for the next hour, every 30 minutes for the next hour, and then you'll check it every hour for 4 hours. Okay, so that's once you have a normalized pressure. So in or outpatient, right? What are we going to do with these patients who have preeclampsia? All right, so outpatient is an option. And now before I say this too, I do want to say like, I can't speak for every patient, right? Obviously every patient's case is individualized. But we can do outpatient management of preeclamptic patients, but it's only for women, right, who maybe have gestational hypertension or preeclampsia without severe features, right? So they have none of those signs and symptoms of an organ dysfunction, and they requires fetal and maternal evaluation. So they will have to be going in pretty frequently. The recommendation is that they go into the physician's office twice a week. They'll be getting NSTs, possibly BPPs. They'll also do ultrasounds to measure fetal growth. Remember we talked about that growth restriction. So you want to make sure you have a good growing baby. And then what was the last thing? Oh yeah, and then they'll do the AFI, right? Now our moms who are going to be monitored outpatient, it's important too to teach them about those kick counts as well. So if any of you are working in an outpatient setting or you're discharging someone home who's maybe still pregnant, always teach them the 10 and 2, I think, of the hands, like when driving. So they should feel 10 movements within 2 hours of the baby. If you have a patient though, right, who has severe features, so if they have a headache or blurred vision, etc., they will require hospitalization for further assessment and monitoring. Or if we have a patient who's maybe not following up with their appointments, we feel like they're not going to come in for monitoring, they as well might need to come for hospitalization. So just make sure that we have a patient who's willing to comply, right, with our recommendations prior to deciding that we can do outpatient management for them. So the plan of care or delivery, just like, with our outpatient, if we decide to monitor someone outpatient, each patient's plan of care will vary slightly. It will be individualized to their needs. But a patient who has gestational hypertension and pre-E without severe features can technically go until 37 weeks gestation. It's really going to depend on how the patient's presenting, right? What their labs are showing, what their signs and symptoms are, and also then how their baby looks and how their baby's tolerating the disease process as well. So it's going to be a multi-factor assessment to determine exactly what we're going to do. Now, these moms who are preterm, right? Typically, those that are less than 34 weeks, not necessarily our late pretermers, but it has been seen that a lot of these women who develop preeclampsia and are less than 34 weeks, they get really sick really, really fast. So a lot of these patients, it's really unpredictable. So it's highly recommended that they stay for at least 24 hours of observation if they're just diagnosed with preeclampsia and they're preterm, just kind of to determine, right, how are they going to do. So really our goal for our moms who are inpatient and have pre-E, Obviously, we want to manage their hypertension, keep that under control, monitor their preeclampsia. So watch, maybe they didn't have many signs and symptoms and now they're developing multiple, right? Watch their urine output, determine risks of eclampsia. We also want to look for HELP syndrome or DIC, abruption. This is something I should have brought up earlier. If you work on labor and delivery, right? Moms who have preeclampsia are at a greater risk for having a placental abruption. What might we see with a mom who's abrupting? So my L&D people.
The pain.
Yeah, that abdominal pain. What might your contractions show?
The wave pattern.
Yeah, like, tachysystole, right? Or that uterine irritability where you're just seeing a lot of contractions, right? Pretty quickly. Our babies won't tolerate, right, this placental abruption pretty long. Mom's going to be in pain, right? She's going to be complaining of, lots of contractions maybe. Babies won't tolerate it very well. So we are going to have to look at our fetal heart rate tracing as well. You can have bleeding if mom abrupts. Sometimes the bleeding is concealed though. So make sure you're looking at your tracing for that. Fetal growth restriction, fetal death, and then a higher chance as well of a neonatal ICU admission if we're delivering early, okay? If they're in the hospital and you are working on an anti-unit, right? So this is maybe our preterm patients that we're taking care of who are in the high-risk unit. Our two main goals, like I said, are going to be control their hypertension. It's going to be number one. You can't cure their preeclampsia, right? It's not going to go away once they have it, they have it. We just have to manage it. And then you want to prevent seizures. Now, our controlling our hypertension we'll do with our antihypertensive, and our seizures we'll do with MAG, which I'm going to talk about on the next slide. But the moms will typically be continuous monitoring, right? Help us look for abruption, helps determine if the baby's experiencing any hypoxia. So we'll do that. We'll also give the mom betamethasone. So she'll get the 2 doses. The 24 hours apart is appropriate for a mom who has preeclampsia. And then fluids, we talked about those strict isonos, right? And I don't think I need to ask you guys again why, right? But you understand, even if mom is allowed to have a general diet, we should still be monitoring, right? How much fluid is she taking in and how much is she putting out, just to make sure we're not seeing a decrease in our kidney function. We talked about management of hypertension as well. We looked at that algorithm. And then with our MAG sulfate. So then I want to hear some other things that if you take care of a patient who's preeclamptic on your high risk unit, what are some other things you guys are doing to help manage preeclamptic patients?
Postpartum, we do stimulus reduction if they're on MAG.
Good. So what does that look like for you guys?
We do like dim lights. We try to keep the patient on bed rest.
Okay. Yeah. Dim the lights. The TV, right? Turning the TV off or down. Cell phones, right? Nowadays, so many people are on their cell phones, whether it's the patient or maybe their support person is on their phone a lot, reducing that. Now in the time of COVID, it's nice, less visitors, right? So that's nice that we don't have to, tell a lot of family like you can't have a ton of people in here, right? To reduce her stimuli. So just think about all those things going around, the monitors, right? The beeping, the sound of the baby's heart rate. What else are you guys doing?
Like checking DTRs and CLONUS and all that fun stuff.
Good. Yeah. You can teach my one slide when we got to it on DTRs, right? So we're doing our neuro assessments, right? And you guys should know your frequency of how often. Are you guys doing them hourly? Is that what you guys are doing?
Yes.
Okay. Yeah, I'd say usually with MAG, it's about every hour, right? That you should be doing a neuro assessment. You should be getting pressures, right? Checking respiratory rates. So please make sure that you're doing those accurately so you don't miss something. And we're going to talk a little bit more about more nursing interventions, but think about environmental stimuli, your neuro assessments you should be doing, just educating the patient as well. They're probably very scared, right, about what's going on. And our patients can oftentimes Google things first, right, before they might be willing to ask you. So just ask them, right, do you understand what's going on? Do you have questions? And that can really help reduce maternal anxiety, which then can hopefully help reduce her blood pressure as well. So it kind of works hand in hand. So the good old magnesium sulfate, right? just to make sure that we emphasize that magnesium is not an antihypertensive. It is not going to bring our patient's blood pressure down, which is why we need to do our antihypertensives in conjunction with our magnesium. So essentially what it does is it relaxes the CNS, hopefully reducing the chance of the mom having a seizure. So it's really going to prevent that seizure activity. And now I cannot emphasize enough, it's oftentimes very common that the patient is ordered, your severe range hypertension protocol will be initiated for the patient, but then also MAG will be ordered as well. It's probably the same order set, right? That both are ordered at the same time. Get both of them, right? Bring them in the room with you at the same time. Have another nurse come with you because you need 2 nurses to check MAGs. It is a high risk medication. Both of you go in, and those things should really be given right simultaneously or pretty quick of each other. We shouldn't be giving, our antihypertensives and then saying, well, let's wait a half hour, right? And see if her pressures come down. Your patient can still seize, right? In that 30 minutes that you're going to wait, it's really not going to make a difference. So you really should be doing those 2 things kind of hand in hand if you can. And I will say, usually when you have a patient, right, who you need MAG, I know L&D people are more than willing to help each other, right? So just ask someone for a hand to come help you start your MAG while you push your antihypertensive. So use caution with impaired renal function patients. So if you have a patient, let's say, who already had some type of kidney damage or kidney failure, I say that because MAG is excreted through the kidneys. So patients who have some type of renal impairment to begin with are at a greater chance for developing MAG toxicity. Okay, so we have to use caution with them. Educate the patients on these side effects. I'm assuming all of you guys have seen MAG, right, being administered at some point in your career. Patients can feel very nauseous. They feel like they're going to throw up. Some of them do throw up. They get a headache, muscle weakness, flushing. The IV hurts where it's infusing. So I've had patients explain to me, like, I feel like my arm is literally breaking off before, right? So I tell my patients all these signs and symptoms, and then if they don't experience any of them, guess what? Great, right? You'd rather tell them than be surprised. So let them know that these are very common signs and symptoms. And then our therapeutic goal of MAG is typically like 4 to 7 or 8, right? Sometimes hospitals may vary a little bit, but this is typically where we want our therapeutic dose of MAG to be. Now, you guys will get calls from lab. If you're a newer nurse, you will have lab calling you. They'll want the nurse for room 4, and they'll want to tell you her MAG level is 6, right? And your response is going to be like, perfect, right? My name is Autumn Miles. You can put it down that I received the lab result. I like it. That's good, right? That is our therapeutic range, right? Where it is more likely that the patient won't have a seizure, right? If we have mom within this therapeutic MAG level, okay? And then what are you guys giving? Are you guys usually giving 4 grams for the bolus? Or any of you guys giving 6?
4.
4?
Or
Okay, yeah. Typically it's 4. I have seen 6 given as well for a bolus. Now, really interesting, I was in a class last week and they were talking about how when you give a patient a 4-gram bolus of MAG, it's like giving our patients, what did they say, 40 milligrams of morphine, right? Which you think about that, that's a lot of morphine, right? We would never give that to a patient. So think about it that way, right? Like we're giving our patient a ton of magnesium. So we need to really do an accurate assessment on blood pressure, respiratory rate, et cetera. So always make sure that you're doing a double check with another nurse. You should have a nurse checking the order with you and then making sure that you're looking at your pump, make sure your lines are all connected appropriately so that you're not putting your patient at risk for developing toxicity, maybe with the wrong dose. And then it is recommended that you always stay with your patient when they're getting that bolus as well to see how they tolerate that MAG bolus. How do babies like magnesium? What's our baby going to look like on the monitor?
Fairly minimal, probably decreased stack cells.
Yeah, good. So we'll see, maybe we can have like a decrease in variability. Magnesium really kind of does the same thing to our baby. So we might see on L&D, right? You guys might see like a MAG baby, right? So decrease in variability, they might appear kind of sleepy. It's not that shocking. Important to let our neo friends know though, right? If we have a mom on MAG, right? Even if the baby's term, that baby might be a little lazy per se at delivery, right? But it's also good for neuroprotection, right? If we are delivering that preterm baby. So mag toxicity, is typically greater than 7 or 8. What might be some signs and symptoms we see in our mom who's mag toxic?
Drowsiness.
Yeah, drowsy.
Yeah, lethargic, unresponsive.
Yeah, lethargic, respiratory rate can be depressed, so less than 12 for your respiratory rate, which is why it's important to do that hourly. A change in mental status, confusion, etc. So those loss of DTRs can mean that we're giving them too much mag, right? So we might have to reduce that. If you suspect that your patient is mag toxic, your first thing that you should do is stop your mag, right? That's what's causing, right, these things. Now, I can't stress the importance of, this is why every hour, right, you should be doing those mag checks, because you might have checked on your patient an hour ago. You could come back in 30 minutes and your patient could be completely mag toxic, very confused, right? Their DTRs are 0. So really make sure that you're adamant about your mag checks. I remember when I was a nurse, I would set my alarm for every 45 minutes. So I knew, all right, that's about at my hour point. I need to go in and start doing my neuro assessment on my patient. So don't forget to do those checks. So you're going to stop your mag, notify physician. They might order the mag level. What's the antidote for mag toxicity? Calcium gluconate, right? So yeah, it's a massive syringe, right, of calcium gluconate that you'll give. It's 1 gram total. It's pushed very slow. So you're gonna push it over 2 minutes because it can lead to hypotension and bradycardia in the mom. So you're gonna push it nice and slow for the patient. Magnesium should stay on during a section and a vaginal delivery. And then my postpartum people, hopefully, right, you're seeing the mag stay on until at least 24 hours postpartum. I am guilty of this as well. So the mag should stay on during a section. I bet you a lot of hospitals are turning it off when you go, I don't know, say you're moving your patient back from a birthing room to the OR. Her preeclampsia doesn't go away, right, when you're doing her section. And that mag really helps you prevent the fact that she'll have a seizure, that she'll become eclamptic. So turning that mag off, right, when the patient goes back to the OR, it's not going to be helpful. So they're really pushing to try and have everyone, and I encourage, I think nurses, we're going to have to be a big advocate for this, is keeping our mag on when we go to the OR. And if that means maybe anesthesia needs to start a second IV in the other patient's arm, then maybe we need to do that. But, patients can still seize on the operating room table, which is a pretty hard thing to manage and watch, right, from an L&D nurse's perspective. So try and keep your mag on, and then keep it on as well for 24 hours postpartum. So this is where I wanted to talk about the DTRs a little bit. And just remembering that you guys are knowing you're normal, right? So our 2+ is normal. If we're down here, I kind of already said it, what could this indicate to us? What are we thinking? We go in, our patient's, none of her reflexes are showing.
Too much mag.
Yeah, too much mag, right? So I might be thinking, my patient is toxic. I think I need to turn this off, right? Get a mag level, etc. So I'm thinking this, or don't always jump to that right away. Do further assessments. Is what if my technique is bad, right? What if you're actually missing the tendon, right? What if you didn't actually hit it? What if she's not relaxed? So do further assessments if you're getting an absence of reflexes, right? If you're getting no reflexes and your patient's like, no, I feel fine, everything's fine. She's confused, she's alert, she knows everything that's going on. You might want to just recheck technique. Now, I can't stress enough, we should not be using the side of stethoscopes. It does not elicit the same response as a reflex hammer. These things are like, I don't know, $5, I think, approximately. Invest in one, ask for one for your birthday, whatever. We should be using a reflex hammer versus the side of our stethoscope. So please make sure that you have one. We know our 2+ is normal, but then what if we're over here, right? What if we're over by our 4+? What are we thinking? We need more mag, right? Yeah, we're probably not at a therapeutic dose where our patient's hyperreflexic. And sometimes you can see that clonus too, where the clonus, right, where you can pull the patient's foot up, you pull their foot a little bit like towards their shin. And then if you let it go, my hand's not a very good example. You can YouTube it, right? And you'll just see, like, if you pull it up, you'll see like like jerking or almost like ticking beats, right? And then to define as clonal, it's 3 beats or more, right? So that foot kind of like pulses when you let it go. So then we're thinking that we are not suppressing, right, that CNS enough. We might need to increase our MAG rate, okay? And both of these things, it's a good time, right, to get a MAG level to really determine, right, where is your patient's at and doing further assessments. So the thing that differentiates obviously preeclampsia from eclampsia is the fact that the patient then seizes, right? So then we shift to eclampsia. And I think that this is really helpful. I liked this acronym of seizure, right? About what you should do, especially if you're a newer nurse who's on here, what you should do. So when your patient seizes, please stay with your patient. Don't run out of the room. I know it's scary and it's terrifying. Press your emergency button, scream for help, right? Whatever you have to do to get someone to come in with you, but you should never leave that patient alone and you need to watch them. Okay. Put the side rails up to protect them, to kind of keep them restrained in the bed so they don't fall and hurt themselves. Notify an attending. The next very first thing is you're going to stay there. And the very next thing is you need to establish an airway. Obviously, if our mom can't breathe, we know further ramifications. So get that airway, make sure that it's stable, make sure that your suction works. This is stepping back even to your patients that are preeclamptic, doing these seizure precautions, like make sure your suction works. I know it seems like something so silly, but you don't want to be stuck with your patient seizing, frothing at the mouth, having a bunch of saliva, and then you can't suction it. So make sure your suctioning is working. And then turn your patient over to their lateral side as well to hopefully, right, get those secretions in the tongue off to the side so their airway stays in place. We want to start fluid resuscitation. Like I said, that zealous observation. So watch them, right? The physician's going to ask you, right, what happened, and it can really help them a lot if you can exactly describe what happened with the seizure. Look at their uterine activity. While a mom is seizing isn't going to be the time, right, to adjust your monitors. My little caveat with that is stabilize your mom, right, so you can stabilize baby, right? Don't be frantic about adjusting your monitors at that point in time. But then when we get mom, right, hopefully resuscitated and stable enough, we need to look at that uterine activity to look for an abruption, right? So we're looking for those frequent contractions, the abdominal pain, and then looking at our fetus as well, okay? If we see that our baby is all of a sudden bradycardic, right? Baby's not recovering, we might be thinking, maybe we're having an abruption, right? And baby's not tolerating it. Now, the pathology of eclampsia, you know, someone once asked me like, well, what's the pathology? Like what exactly happens? We aren't fully 100% sure exactly, right, what happens, about what is the one thing, right, that pushes a woman over the edge into an eclamptic seizure. But I read on Up to Date, some things that they said was that it's due to those vasoconstrictions of those cerebral blood vessels, the hypoperfusion and the local ischemia then that can lead to this eclamptic seizure that we see in our patients. So can't exactly say one specific thing, but we do know that the MAG helps, right? And then I always just say be prepared, right? So you're ready to manage it. The next thing that can happen from preeclampsia or eclampsia is going to be something called PRES. Now this is very rare. It's posterior reversible encephalopathy. Essentially what it is it's secondary to hypertension or eclampsia. Patients start to develop a headache, they get vision changes, they can become completely confused. And it's diagnosed through an MRI. So you might have a patient who needs to get imaging to determine if they have PRES, and it's reversible. So I will say a lot of most patients do recover from this, but it's scary to look at. You can see this whitening per se, right, of the matter within the brain. Patients can become so confused that they don't even know that they had a baby. They're confused into why they're there. So it can be really scary to watch, severe headaches, etc. So they might require like neuro ICU admission, et cetera, and a prolonged hospitalization, but most of them will get better and recover that neurological functioning that we see deteriorate. So fetal assessment, sorry guys, we're cutting it kind of close here. So fetal assessment, obviously if you have your patient inpatient or if she's outpatient, mom should always be doing those daily fetal movements. NSTs or BPPs will be done about twice a week if they're outpatient. Obviously, if they're inpatient, you'll be doing NSTs 3 times, once a shift usually. And then ultrasounds they'll be monitoring to check on that fetal growth to determine maybe is that placenta worsening, is the disease progressing that we need to deliver. We should give steroids, like I said, always have the neonatologist consult. Remember, especially if she's preterm, very anxiety provoking, right? It can be very scary. The mom's sick. She doesn't know what's going to happen with her baby now. So trying to give her as much knowledge or reassurance that she needs, right, prior to delivery. And then is delivery needed for maternal or feeder indications? Now, this is when it's really patient specific. I can't tell you at every week, this is when this patient's going to be exactly delivered, or this patient's always going to be delivered at 38 weeks, etc. You really need to look at how's your mom doing? What are her symptoms? What are her lab results showing? What is our baby exemplifying, right, on their ultrasounds and on their monitor tracings? So you're really gonna have to weigh the risks and benefits of deliver or don't deliver. So again, like I said earlier, preeclampsia does not go away when a woman delivers, and the postpartum period is very, very dangerous. So to my postpartum nurses who are on here, I cannot stress this enough with doing your assessments, right? Even if they weren't preeclamptic in their intrapartum period or antepartum, and when you're discharging them home, right? There are patients that still go home that might develop preeclampsia. They might come back for a readmission, 2 weeks later, right? And it's nothing we did wrong, right? The patient might have just developed it later, but they need to know, right? Even if they didn't have it. So everyone should be educated. I know some hospitals have the bands that they put on their patients, like the hypertension bands. They're like little plastic, kind of like those Livestrong bands that everyone used to wear, that literally say like preeclampsia or severe, hypertension on them. And I think that that's good for them to wear. And then for the patient to know, right, that if they go to an ER, right, or if they go to their primary care physician, that they tell them, I just had a baby 2 weeks ago, or I had preeclampsia. How we handle preeclampsia, right, and maybe how an ER and urgent care handles hypertension are totally different. So we need to make sure that those patients are aware too, for themselves when they go home. So late postpartum eclampsia can happen greater than 48 hours after delivery. And like I said, up to 6 weeks, they can develop this. And it accounts for about 15% of eclampsia cases, with 63% of them, like I said, having no antepartum hypertensive diagnosis. That's a lot of people, right? Not knowing that they had this, and now they're having this horrible eclamptic episode later. So hence the education to everybody. And then blood pressure evaluation is not predictive of eclampsia, right? So you can't say like, oh, my patient that had a blood pressure of 200s over 110 versus my patient of 160 over 110. Every patient is different. Every patient's body is going to respond different. I might have a patient C's at 160 over 110 and be totally fine with the 200s, right? So it depends on the patient. And then I just wanted to emphasize the most common presenting symptom postpartum when they come back is going to be a headache. So it said 70% of women who came back postpartum were complaining of a headache. And unfortunately, it was talked about why are people missing it. And they were talking about how a headache, right? A woman's postpartum, right? She's stressed, she's overwhelmed. That's why she has a headache. But really 70% of these eclamptic women were presenting with a headache. So we make sure to watch them. They still have the blurry vision, edema, that nausea, vomiting, epigastric pain as well. So these are all different complications. I'm not going to go through them. HELP, DIC are the most common ones that we see in oftentimes inpatient. They can develop chronic hypertension. We talked about abruption. They can actually have a liver rupture as well, renal failure that could lead to dialysis, cardiovascular disease, and ARDS. To prevent preeclampsia, there's not really one thing that I can tell you is, yes, this is going to prevent it if our patients 100% of the time do this, but really preconception counseling is going to be key, making sure we know their history, they have appropriate weight, multifetal gestation, etc. Making sure that they're going to regular medical care visits and that they're notifying physicians that they maybe had a history of preeclampsia. And then as well, any other metabolic disorders that maybe they had pre-conception, we want to make sure that those are managed well throughout their pregnancy. The more we can manage hypertension, diabetes, right? Maybe aspirin as well as something like the baby aspirin, the 81 milligrams they recommend can really help reduce the incidence of preeclampsia from developing later. So discharge and follow-up. At University of Chicago, we keep all of our hypertensive patients inpatient for 3 days because of this increased risks of developing preeclampsia and eclampsia. They should follow up within 72 hours if they're discharged home on any antihypertensives for a blood pressure check. And then within 7 to 10 days, if there's no medications for blood pressure evaluation. So specific education, like everything I have taught you guys, right, in this past hour, we should be telling our patients. The signs and symptoms, right? Do they have a blood pressure cuff? There's multiple programs that they can get a cuff. So teach them all the signs and symptoms. Get them a cuff, have them show you they know how to accurately check their blood pressure, and that they know who to call and when to call, right, if their blood pressure is elevated. And then just debriefing is really important. So make sure that you're following up with everyone. If you had a patient who had a severe hypertensive crisis, asking those other nurses who worked with you, those physicians, the residences, etc. What did we do well? What could we have done better? Maybe to act a little bit quicker on our next patient who has a hypertensive crisis. I will tell you, you will feel more comfortable, right, if you debrief a scenario in the next case, right, when it happens to you again, because you're like, I've done this before, right? I know what to do. I know I should do this better next time, etc. So I think it's really, really helpful to debrief a severe hypertensive scenario or an eclamptic one as well. So I know this is really pixelated, it's hard to see. And I redid these recently, but we do have badge cards that do have the algorithm on them with the antihypertensive, when you should check the blood pressures, how much labetalol, hydralazine, nifedipine you should give, the time frames, etc. So I know I distributed these to some of the hospitals. If you don't have them and you would like a copy, please feel free to reach out to your educator or to myself directly. You guys probably all have my email. I'm happy to email these slides to you if you would like them, as well as this badge card. So please let me know if that's something that you would like. I think it's just helpful to have it on your badge with you.
I definitely would like some.
Okay, cool. So just shoot me an email. Yeah, whoever wants the badge cards, I'd be happy to send them over. And then some key points just to conclude is that preeclampsia, remember, is a severe generalized disorder affecting all major organs. It's important to know the uses, your dosages of the magnesium, as well as the antihypertensives, and then the time frame, right? Hopefully within less than 30 minutes, they're both being given. The risks of postpartum preeclampsia is almost, just a little bit higher, right, than the intra and antepartum. And then nursing implications and management for patients with preeclampsia. Okay. Are there any questions at all for me? Oops, sorry. If you